Hello, everybody. It's time for a new GYN Garage. My name's Ed Pavlik. I'm in Lexington, Kentucky. My colleague here is
Frank Lawson in London, United Kingdom.
Frank. I've just learned about something
Oh,
called
yes.
AO conning. Tell me about AO conning if you've ever been involved this holiday season.
No, I haven't. What is it?
It's apparently a part of the hierarchy of servants, civil servants in London who actually go from AO serving place to AO serving place, deciding on the quality.
Oh, you mean a pub crawl?
I guess so, but these are
That's what we
official,
did as a student anyway.
these are paid officials who
Oh, yes.
who are doing this, and I'm told this was on the BBC that those establishments that have a higher quality receive a wreath on their door with something to do with the AO conning establishment. So,
Right.
well,
And these are
I expected you to tell me something about it.
no, and these are civil servants, are they?
They're
Doing
also, yeah, I think they're civil servants, but they might
well,
be.
that's why the country's gone to the dogs if they're all in the pub getting smashed all the time. Yeah, it's interesting. Quite a number of the pubs around Westminster have bells in them, so that if any MPs are having a pint or two and they need to go to a division, there's going to be a vote. The bell will ring, and they know they have to get back to the House of Commons within a few minutes because there's going to be a division and a vote on a particular government bill. And quite a few of the pubs have still got these, within about I don't know, half a mile or a mile of the House of Parliament so that they can have a swift beer and still get back in time to pretend that they're running the country.
Pretty efficient deceit.
Absolutely, yes, it's exactly. Yes, perhaps we is it your new boys going to bring in Elon Musk to bring in lots of ways to save money in big government? Isn't that what Trump's going to do? Perhaps we should bring him over here and talk about pub crawls for civil servants.
Yeah, I guess so. I'm reluctant. Well, we have just lost the compromise budget that both the sides, Republicans and Democrats, were agreed upon. And so we'll see what happens this weekend. The country will not have a budget. So
Oh well,
we'll,
right.
we'll probably still spend money, but we won't do it on a budget. Well, today, Frank, we're going to consider the question, what are the considerations for conducting a full-scale random controlled trial comparing minimally invasive surgery versus laparotomy, both after neoadjuvant chemotherapy? Uh, the answer to this question is approached in a paper titled Laparoscopic Cytoreduction after Neoadjuvant Chemotherapy in High-Grade Epithelial Ovarian Cancer, a Lance randomized clinical trial that was published in JAMA Network. Frank, we're going to look at this both from a human and an artificial intelligence
Okay.
standpoint. And the human is up first. Go to it, Frank.
Okay. Um, a bit of a history first about this. In 1975, with an NIH monograph from Tom Griffiths about the advantages of maximum surgical cytoreduction in ovarian cancer, and that has stayed as the gold standard for the last 50 odd years. With the instant or with the increase in use of neoadjuvant chemotherapy to shrink tumors before surgery, there's been a big increase, I think, in practitioners saying yes, we can do it laparoscopically, and the morbidity is much less, the outcomes are much the same. But these are all observational studies. There hasn't been a randomized controlled trial of laparoscopic versus open laparotomy in advanced ovarian cancer, with the end result being how much disease you've left behind. Is it important to do this study? I think the study is important in a way because the authors quite rightly, and we have reviewed this study before, the LAC study looking at minimal access surgery in cervical cancer. And as we reported originally, when we reported it, there was nearly a 4 times increase in recurrence rates in the patients who'd undergone laparoscopic surgery for their cervical cancer compared with the ones that had undergone open surgery. And the study was prematurely stopped because of these results. And now I think it is agreed that laparoscopic surgery is not the surgery of choice for patients with cervical carcinoma. So the authors of this paper have picked up on that and say, well, is it the treatment of choice for advanced ovarian cancer? And what they have done is reported a feasibility study. The feasibility study is saying, with the end results being, can we recruit enough patients to make the study worthwhile? Is the conversion rate from laparoscopic surgery to open because the laparoscopic surgery is not appropriate, adequate? And what are the gross resection rates? Do they end up with the same volume of tumor at the end? And I think really from that point of view, this study shows, yes, they can recruit. They only want 5 patients a month. The conversion rate was only 12% from laparoscopy to laparotomy, which is acceptable to the authors. And the maximum debulking rates were 80-odd% in either arm of the study. So I don't think there's a problem with that. And as you'd expect, the authors have looked at the morbidity and the morbidity of the surgery. The surgery is quicker the surgery may be slower, but the outcome is the same. They're in hospital for less, the blood loss is less, the morbidity is less, all of the things that we know with laparoscopic surgery. The problem, I think, is in the end, this widened study is really going to be a toxicity study, because if the outcome is the same, 80-odd% maximum debulking, they're all going to get neoadjuvant chemotherapy. All they're going to be able to report is that laparoscopic surgery is less toxic than open laparotomy, which we know. If they find, of course, that there is a disadvantage to laparoscopic surgery, then that may be a very good output. But I'm not so sure whether the study will be able to show that. So I think it's essentially a feasibility study that's going to lead to, unfortunately, just a randomized toxicity study of 2 surgical approaches to advanced ovarian cancer. And there's a lot of people going to get involved in this, and I'm not so sure that it will produce the answers that they want. I hope it does. I hope it does give us more indications as to the role of minimal access surgery in gynecological cancers, but we shall have to see.
Well, that's right. I think the complication that I want to point out is that if you have just 2 arms, and considering what they proposed, and that's the minimally invasive versus laparotomy, you leave out partial responses to neoadjuvant versus complete responses as perhaps a variable that will affect the outcome. And so that, in my mind, creates 2 more arms. And then now of those 2 arms that are created, you could say, well, basically you're duplicating what I've shown here as arm 1 and arm 2, and that's possible. But the other question boils down to is, would with and without BEV be a factor in how minimally invasive weights itself against laparotomy? And so I'm very unsure, if someone asked me to power this study, how I would power it, based upon what's in this paper. I agree with you, it'll be a toxicity study, but I think also the accrual rates were over a 3-year period at 5 point something per month, something like that. I think the study would have to be larger and longer. And basically they're talking about 50 and 50 in 2 arms. I'm thinking it would probably have to be closer to maybe 500 to 800 people total, that type of size. But they're going to go forward with this, and they'll have to deal with this with whoever is going to support this type of trial.
Sure.
Uh,
And obviously, I think it does reduce. I mean, the patients have got to have a normalized CA125. They've got to have imaging that suggests that it is operable in the first place. The resection rates are going to be pretty much the same. And I think you're right. If all this is going to show is the different toxicity of open laparotomy versus laparoscopy, because I suspect the results with an 88% complete resection, the overall survival and 5-year survivals of those two groups are going to be very, very similar. So unless it's abandoned prematurely because of the toxicity of laparoscopy, then I don't think this is actually going to show anything at all about the therapy itself. It's just a toxicity study, and it's a very large and complicated toxicity study, I'm afraid.
well, that's absolutely true. I guess what I'd like to point out is that we've shared the analysis with both Gemini and
Oh, yeah.
Copilot again, and we basically said to them, critically analyze, and then what we've said to analyze, either the address given by the DOI number or the actual URL. And it's interesting, the results we've got this time. In the past, when we've done this, either they both perform the same or Copilot performed better. And when one of them couldn't perform, it just said, maybe this is behind a paywall, or maybe it couldn't be accessed. But this time, the answer we got from Gemini was the equivalent of you going into a tavern and asking for baked chicken and off the menu. And basically, the response the server would give you would be, you have to understand your request first. Before we dive into giving you your baked chicken, let's clarify what baking means. And in this context, we need to critically analyze how long the baking process will occur and how you will evaluate it as truly being baked. So essentially what they've done is given us a list of what we should do on our own rather than what Gemini would do for us. And that's all very interesting. Now, the second thing that surprised me and hasn't occurred before is and let me say right here, I'm showing you the type of response you get when they can't find something, that they apologize, which is nice. I'm not able to access the website you provided. The most common reasons is the content may not be available to me because of paywalls, login requirements, or sensitive information. But there are other reasons I may not be able to access it. That's a common response I've seen with artificial intelligence, but not the first one that I described. Now with Copilot, basically I said critically analyze the address at the DOI number. And the most amazing thing happened. It went to some other paper.
Absolutely. That's interesting. Yes.
And so then I repeated the request. I said, critically analyze the URL that the paper was at. And it found yet another paper on fostamatinib, whatever it is, for treatment with COVID. I don't know what's happening here, if this is a hallucination or some sort of other problem, that's caused. So anyway, what I'm really, up against here is we can't really tell you what artificial intelligence can help us with. And both of them really sort of failed the usage test for this particular paper.
Interesting.
So
our viewers are going to have to rely on our intelligence rather than the computer's intelligence or artificial intelligence.
right. And, we have to recognize again that the strength so far of these large language model chatbots is that they're quite literate. Whether they're right or wrong, they're quite literate.
Yes.
And the task now will become, in their general usage for physicians, is to pursue not only how well they sound, but are they sounding on the right things? And
Yes.
and then that raises the question, will it take longer to do that? if
Yeah.
however you're responding, will it take you longer to think about what they said, and then maybe to write your own note because you don't agree with what they've presented.
Sure. You probably ought to tell them, the companies that run them, that there's a glitch in the program, that for some reason you've told the robot to look at something and it's gone somewhere else, done it twice. It's completely blanked out. And because
Yeah.
I can't believe it's behind a paywall. If we've got access to it and you've got access to it, it's not behind a paywall.
Well, it's not, it's open access. I mean,
Exactly.
clearly that. So, well, with regard to that, you and I have a paper that will emerge sometime on this very thing with every paper that we do, and I'm just recruiting some med students to join us on papers we've done in the past to see how Gemini and Copilot work out. Well, Frank, we've done it again,
We have.
and it's time to say we'll see you again later.
Okay. See you soon. Take care.